some normal respiratory physiology. So TTN, transient tachypnea of the newborn. I mean, it's in the name, it's transient tachypnea of the newborn, but most importantly, you can think of it like, or the way I like to think of it as I think of it like my CHF patients in the adult world. I mean, it's basically volume. It's like a state of volume overload, but not complete volume overload like a heart failure patient, but it's basically just in the chest. And so it's more common in cesarean sections. And part of that's because there is some component of compression through the canal as they come through a standard vaginal delivery. And so that helps somewhat. But I guess I should preface with the fluid. And they're like practice breathing in the womb. So, there's separate fluid. Now, obviously, it bleeds off into the amniotic fluid, and that's why you use the sphingomyosin to lecithin ratio to try to determine their maturation. But for the most part, that fluid is technically should be separate. And they have their own separate, they just call it lung fluid, because we're just fancy as doctors. What else would we call it? But it's got those proteins and the peptidoglycans that keep those alveoli from collapsing, like the surfactant. And so essentially what should happen when they inspire and they take their first breath, they should have an immediate, well, I guess I should ask you, when you inspire, what happens to the pressure in your chest?
Right. It looks like...
No. It is a negative pressure. When you inspire, you create a vacuum. That's what sucks the air in. Like when you pull with your diaphragm, what you're doing is you're creating a vacuum. So you have negative intrathoracic pressure. That is also why what is the most common arrhythmia of pediatrics? That's technically not an arrhythmia, but sinus arrhythmia. And the reason that they have a sinus arrhythmia, and essentially what that is, when you listen to them with your stethoscope, you'll think it's abnormal, but when they breathe in, their heart rate will go up, and when they breathe out, it will slow down. So when you create negative intrathoracic pressure, you create a vacuum, not just for air. It also has a vacuum and pulls in preload. And so your preload will increase when you inspire. And that's why to compensate for the cardiac output, their heart rate goes up. But it's a completely normal finding just because of how their chest cavity in relation to their body is. But it's important to know that there's a big negative intrathoracic pressure that has to happen to get air in. But you are correct in that when they take that first breath in and they breathe out, they need to create a bunch of positive pressure because that's the only thing that's going to get the fluid to absorb. And that's really the mainstay of treatment. I know we do piddly things like we can put them on a little oxygen. Sometimes I do it just to make me or make you feel better. But really it's the pressure that they need because that's the driving force to get fluid out of the lungs. Because we're not going to diurese the babies. Nobody diureses babies. That's what we do for the old people. But for the babies, essentially what we want to do is put them on a little CPAP. Or when you first deliver them, ideally what I would do whenever I was a resident and we would go down to cesarean sections, I immediately, when that baby got over the table, I went ahead and put that lead IV on it. And I gave them a few breaths, with some pressure, because that's what I wanted to do, was try to keep them from getting TTN. I wanted to kind of drive that in for a second, not because they had distress. And they tended to perk up and do a little bit better. But that's why whenever they're in here, we'll typically say, put them on CPAP. Because that's what you want. You just want some form of positive pressure to help drive that in. And if they didn't get that either through a natural standard vaginal delivery or they had a regular vaginal delivery and they just have a little fluid on their lungs, that would be the most important thing. You're also not wrong, though, to give them a little permissive tachypnea. If they're just not tacking away and, they're not going to just go into respiratory failure or rest, then, you can kind of let them hover around, I would say like the mid-80s. Now, once they're getting up to like 90 and 100, okay, we need to put them on a CPAP because they're going to work themselves till they become hypoxic and hypercapnic. But I would almost say it would probably be a good idea to give them a little permissive if they're not getting past that level and they don't look to, be hypoxic or have worsening vitals. But if they truly, truly needed anything to be corrected, the main physiologic consequence, and this is why the chest x-rays look the way they do, is they basically just have increased cephalization. They just have increased fluid. And I'm sure you've probably all seen something like this a bajillion times.
Sure.
The really main thing I would say is the difference between TTN and true respiratory distress is that, when we got kids with true RDS, like their lungs are widened out everywhere. Now you take into consideration the thymic shadow and stuff, but essentially it just kind of looks like an old 85-year-old lady with CHF. You kind of just see all this branching cephalization on the X-ray, and so there's no focal infiltrates, and you shouldn't see that. And so if otherwise we just got a little one that comes out, they're just a smidge hypoxic, they're a little tachypnic, and they've got an X-ray on this, you really just have multiple ways you can do it. I mean, as long as you are comfortable and they seem to be comfortable and they're feeding well, watch them. Because I mean, in theory, over time that fluid will absorb, and within a few days it should resolve. Now it could last up to 7 days. Some cases of TTN last for a while, but I've rarely ever seen that happen here. Usually by the time they hit that 24, 48 hour mark that we've had to observe them, they're breathing more comfortably. That or they didn't and we shipped them in. But pretty much it's giving them the positive pressure, and I would almost say, not that you have to do it, but like say if I'm on call and you're delivering a cesarean section baby, and they come out, if they have a little bit of a rough cry and they just sound kind of, I would rather you give them a little bit of NIV right then. Just drive some of that in, because that's exactly what you're doing. Every time you give them positive pressure, you're driving that fluid in, and that's what's going to solve the problem. And if they are hypoxic, we could give them a little whiff of oxygen, or if it did decrease their work of breathing, that would be fine. But I would probably lean more towards if they truly are tachypnic and they're getting up to the 90s and they seem to be having trouble with their feeds, then I would probably just put them on CPAP, and probably just at room air, because the pressure is what they need. But what questions, I mean, just in general, about TTN or about their respiratory status or about just breathing in general, would you have questions about? So we're all going to know that pretty much the main drive for our respiratory is going to be carbon dioxide rather than oxygen, unless you're a 75-year-old smoker. And so, that's really, again, that's what's driving their respiratory rate. And so, we probably should focus more on, the ability to do venous gases. And I know there's an I stat here. I don't really get into that. I think really for TTN, they shouldn't be crashing. If they're crashing, it's not TTN. Like, you just wouldn't even be dealing with it. And so if they're really that sick, that's not really on the differential anymore. Like, if it's TTN, you're calling me because they're just a little tachypnic and you felt a little uncomfortable just because how fast they were breathing. Maybe they're borderline 90s or high 80s, but if it's really much worse than that, it's probably not TTN. We probably just need to be a little bit more aggressive with their respiratory status.
What about like deep suction? Does that help with it at all?
Because it's not going to drive that fluid in, and there's no way you're going to have a suction catheter that can go down and then get small enough down to, you'd have to get it to the alveolar level. There's just no way you'd be able to suck it out. And that's probably another reason why they've kind of moved against that whole, if they're met, just go ahead and waterboard them and take it out, because it just doesn't really, even for meconium, once it gets down in there, like when you're looking at the chest x-rays, like it gets down. Like, you can't just suck that out. Like, you may suck a little bit out and make yourself feel better, but what's down there that's causing the problem is there. It's still going to have an inflammatory reaction, and it will still be fluid that you're driving in. The problem with meconium is that it's sticky and it can create a ball valve effect, and so they can become hyperinflated, which is a whole other problem we can get. But no, just doing that suction's not, because once it gets down in there and they've taken that breath, they've had positive pressure push that as far down as it can get. And so if it's either going to have to be fluid that can be absorbed, or there'll be an inflammatory reaction, they'll have some respiratory distress until they get over it. But no, like once you get that meconium down there, you're not sucking it. It's in there. Kind of like when they do, I don't know if you've ever seen a BAL, bronchial alveolar lavage. So when they go in there with that camera and they're down in the lungs and they do a lavage, it's a lavage. They basically just start vial after vial. They just start shoving saline in their lungs. Which sounds uncomfortable, and it's uncomfortable to watch them do. But when they aspirate and pull back, they don't get all the fluid back. They maybe get half to 75% if they're lucky. So what happens to the rest of that fluid? They absorb. Like, they put them back on the vent and they do driving pressures and they force that fluid back in. Because you're not getting it all back out. There's just no way. And
So
that would be
essentially that's what we would be trying to do, like with
Exactly. That's what you're trying to do. We're trying to drive the fluid in. Because they're not in a true volume overload state, from the vascular standpoint, like a CHF patient, so you can't diurese them. But basically they came out of the womb with their lungs full of fluid. They took the first breath and they tried to absorb as much as they can, but they just had a little trouble. And so that's essentially what we're doing. We're just trying to increase our pressure to drive the fluid in.
So if we're doing CPAP and our stats aren't like going up, is that what tells us like, okay, it's something different?
Well, it's obvious that we'd have to take it by the situation. But let's say you had a baby, you got them on, you put them on the CPAP, and they're starting to become more hypoxic. You would start to think to that next step of, okay, is it just fluid? Was there meconium? Could they have some kind of infiltrate? Do they have a pneumothorax? To answer that, yes, I would change the shift in my mind, because your thought is if this is solely TTO, this is solely just excess fluid in the lung that needs to be reabsorbed, they should improve. And so if they're not improving, just like if you're doing a code and you get to that point in the resuscitation where everybody's kind of got the thinking caps on and you're going through your, what do they call the T's and the thing. You go through your list of what could this be? Could it be whatever? But, and so you do. Then you start shifting and be like, okay, give them a little oxygen, get a chest x-ray, make sure they don't have a pneumothorax, make sure that they don't have an infiltrate or something like that. Because in theory, if you put them on the CPAP, they should improve. They should improve. And honestly, in TTN, most of the time, you're chasing the respiratory rate, not their hypoxia. Or if you are chasing the hypoxia, it takes like a liter to get it up, because they're just hypoxic if they are. But you're trying to chase the respiratory effort rather than their hypoxia. And I mean, if you can put that pressure on and drive the fluid in, you'll alleviate the work that they have.
So flow by essentially is not gonna.
It makes me and you feel better. It makes me and you feel better.
Yeah.
It really makes us feel better. But that's not going to, other than just maybe if you can get it right up the nose, make a couple of that oxygen look better, you're not going to help their gas exchange, and you're not going to help their work of breathing. Again, because it's going to make their oxygen look better and make you and I feel better, but that's not what's driving the respiratory rate. It's the true gas exchange, the carbon dioxide. And so that is going to impact their drive more than anything. And you can think, if there's a bunch of fluid there, you're not exchanging the gas well. What was it? Classically, if you looked at a PFT on like a COPD patient, where you're trying to figure out, do they have more of like a gas exchange problem, or is it the member, there's a diffusion coefficient that you can check. And essentially that's what would be abnormal in them. I think that diffusion coefficient will be abnormal because they're not getting that gas exchange because of the fluid. But if we can give them a little pressure and drive it in, it should correct. And obviously we'll take each clinical situation into context, like, are there risk factors for infection and other things. But for the most part, these are usually cases where it was a C-section, they came out, they're a little tachypnic, maybe slightly hypoxic, no other infectious risk factors, and you're like, okay, well, give them a CPAP. What else would you like to do? Because we can talk about anything. Anything about like the mechanics, like about breathing, about.
So what can we do like during the transition period? Because I feel.
I'm sorry.
Like that's where we're gonna usually see it is during that 2-hour transition. We're trying to give them skin to skin. We're trying to let them kind of fix themselves on their own. What can we do while they're like skin to skin to fix anything? Is like proning helpful at all? Anything? Nothing? No.
No, I mean, there's really not going to be anything that if they're skin to skin with mom, I mean, really the only main effective thing we can do is give them more pressure. And so there's just really not going to be a way if they're a mom to do that. But at the same time, that's why I say, if they're not just tacking away over 100 or something, like in the 90s, and it's just like in the 80s or like low 90s, and they look okay, give them that transition, give them a chance. Let them see. Like they can have some permissive. If it keeps on, they're persistently tachypnic and they're climbing up into the high 90s and they're struggling, we can probably just put them on some CPAP. But no, there's really not any kind of fancy technique or special thing I can tell you to do if they're on mom.
We try to fix them before we have to take them so the moms don't freak out. So.
Yeah. Now, how can I explain why sometimes skin to skin makes that better? That's that. What's the word we use when we don't know? Idiopathic
Yeah.
means I don't know.
It's all magic.
For real.
Yeah.
For real.
Mhm.
That is not so magic.
Yeah, because in theory, if you're gonna do anything for them, you just have to put them on CPAP. I guess you can put them on CPAP and put it back on mom.
So you can just do like, it's okay if I weigh and do my measurements and weigh and then be
What?
like, well, we're sounding a little junky. Let me just do a little bit of this.
Do you know how much you weigh?
Yeah.
Well, sometimes if you're worried, just say, I need the baby.
Yeah.
Like I've been so many times in my residency, I've gone over there, and there's so I appreciate skin to skin, but when you take the baby straight to skin, and that baby hasn't cried once, and that baby's not moving, and is kind of looks like you're about to pronounce them on the mom's chest, ask for the baby.
You have an algorithm for that.
Well, at OU they don't, because I've had to ask them for the baby, because they won't give it to you. Yeah. Like, okay. And bring me the NIV. So it happens. Well, maybe not here, but up there it does. But really and truly, what else from like at least it can be about anything, but I don't know we're talking about the respiratory.
I'm trying to think.
I'll have questions in a moment.
I know, that's what I was thinking.
When you leave, we'll have a list.
Okay.
Or when we have a bad baby, we'll have questions. We'll make sure we call you at 2 in the morning.
Hey, remember that one time, what'd you say?
CPAP.
CPAP. Just give him a little CPAP.
CPAP. With NIV, give them some good breaths. Don't crank your pressure too high. But give them drive it in. And give them the breast just like you would when you're doing it. 1, 2, 3, 1, 2. Just give them a good until you drive it in. But that's pretty much the main points that I try to say. Is kind of know how some of the like pressures are, and just know that you just need to drive the fluid in. Like that's the main issue. And diuresis isn't the goal because they're not a vascular volume overload. Like the fluid is just already there. It just needs to be reabsorbed.
So these are confusions like C-section patients or like precipitous deliveries, like
Exactly.
babies that aren't getting
Yeah, they're not getting that good. Yeah, getting that good squeeze to come down. Yeah. Well,
So if it.
hey, when you asked to record this, you didn't tell me that. Hey.
If it's respiratory distress, is CPAP not gonna make it?
It'll still make it better.
It'll still make
Just
it.
know in RDS, then it kind of shifts. The still main thing is the gas exchange for carbon dioxide, but then you probably are giving them much more supplemental oxygen because those babies are usually more hypoxic. Because those true respiratory distress babies, that's why they're whited out. They have alveolar collapse, and that's why they get surfed. And then we put them on the vent, and we're just doing what we can to increase their PEEP and open those alveoli back up. So they will require much more oxygen. Whereas these babies you just put them on room air, just give them the pressure. When an RDS baby, we're probably going to have to surf and ship, depending on the severity. But just because I know it doesn't happen very much.
That wasn't me.
I just don't see it, or you can correct me if I'm wrong. I just don't know of many pediatricians here tubing to surf and then extubating to see what happens. Unless it's happening and I don't know about it. Okay. I didn't think so.